Yeah, it's anxiety provoking for sure, but we're all okay. So welcome everybody. Thank you guys for joining. We are officially live here with the International OCD Foundation. Today we have two wonderful speakers joining us, so I'm going to wait just a few minutes to let everybody join before I do introductions and we get started. So as always, we ask you guys to put some comments in the right box where it says comments. Let us know who you are, where you're from, and kind of what you're looking for as we get started today. So a couple disclaimers as always, this is not intended to replace treatment, but instead is an educational series. So the point of these talks is for us to share educational content, educational experiences and background that hopefully you can learn from, but for specific treatment advice and recommendations, we really want you to seek out your individual clinician or an individual clinician in your area. If you're feeling unsafe or suicidal, please call 911. Go to your local emergency room or call the suicide hotline. As you can see, the crisis line is right there below, so 800-273-8255. Thank you, as always, to the International OCD Foundation for hosting these. These are a webinar series that we started back at the beginning of COVID as an opportunity to reach out to consumers and share more related to information, education, content, and resources, all things OCD and anxiety. So today we're going to be talking about misophonia. So we're not going to be talking as much about specific OCD like we usually do. And instead it's going to be on a similar or related illness or disorder. So today is part one. Part one is going to be really professional. So we're going to be talking about professional education content. So how would you diagnose? What does treatment look like? What do you recommend to be able to help individuals get from a place of suffering to a place of management who are dealing with this disorder? And then part two, Dr. Storch and Ethan Smith will be doing a town hall later on with the International OCD Foundation and an individual who's going to speak with lived experience. And so most of this content, a lot of you might think, well, this is interesting, but it's a new wave that we're doing with IOCDF. We're doing two parts. So part one is more of introduction to the illness, introduction to the disease, the professional content, and then part two is the personal content. Hi to so many, and thank you for joining. So let's get started. So today we're going to be talking about misophonia. We're going to talk about some of the updated research, treatment, diagnostic criteria, basics, and understanding. And we're joined by two leading experts in the field. Many of you know their faces, Dr. Dean McKay and Dr. Eric Storch. Dr. Dean McKay is a professor of psychology at Fordham University. He was the president of the Association for Behavioral and Cognitive Therapies in 2014 and the Society for a Science of Clinical Psychology in 2018. He's currently associate editor of Behavioral Therapy, the Journal of Obsessive Compulsive and Related Disorders, as well as the Bulletin of the Menninger Clinic. He also serves on other editorial boards of 9 journals. He's edited and co-edited 20 books dealing with the treatment of complex cases in children and adults, OCD, disgust and psychopathology, and research methodology. Dr. McKay has published over 300 journal articles and book chapters and has over 350 conference presentations. He's board certified in both CBT, cognitive behavioral and clinical psychology with the American Board of Professional Psychology, as well as he is a fellow of APA, ABCT, and APS. He serves on the Scientific Council of the Anxiety and Depression Association of America, the Scientific Advisory Board right here at the International OCD Foundation. And in addition to misophonia, his research has focused primarily on obsessive compulsive disorder, other anxiety disorders, and the role of disgust and psychopathology. Thank you so much for joining us, Dr. McKay. We're excited to have you here.
Thanks. It's a pleasure to be here.
And our other presenter is Dr. Eric Storch, who is a personal mentor of mine. He's a professor and a presidential endowed chair at the Menninger Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. He serves as vice chair and head of psychology and oversees the CBT for OCD program at BCM. Dr. Storch specializes in the nature and treatment of childhood and adult obsessive compulsive disorder, anxiety disorders, PTSD, and anxiety among youth with autism. He's received multiple grants to investigate treatment efficacy, mechanisms of action, and how to enhance outcomes for those struggling with these conditions. And he is world-renowned for his research and work that he does in the field. Thank you so much for joining us, Dr. Storch. We're excited to have you here.
Oh, thanks. It's great to be with both of you guys.
Thank you. So let's hop in. So whoever wants to start with a little bit, if you don't mind, of just kind of what is this? Like, what is this illness? What does it look like? And who are, like, when do we often see it appear? So often we're talking about OCD and related conditions here. So do we see misophonia often with OCD? What does it look like? Who wants to start?
How about the guy with 20 books?
Well, I did co-edit a lot of those with Eric, by the way, so unmentioned in the intro. I'm happy to start. So, so I'll mention from a data standpoint, there's an interesting divide here. So if you look in the published literature, there are a number of cases that have been reported where misophonia occurred with OCD. And so there's been this prevailing assumption that the two conditions seem to go together. And for me personally, I got involved in this in part by attending the OC Foundation meeting one year. And at that meeting, for those of you that are regulars at that conference, there's a lot of commingling of people who are consumers who are either suffering from OCD or have family members who are, as well as clinicians. And at that particular conference, there were a lot of people who were there asking questions about misophonia, and in particular asking about how it was related to OCD. And these were people who suffered from the condition. In my lab, at least, we've not yet published the data, but we're getting ready to. We've collected a lot of data on treatment-seeking individuals with misophonia, and actually the rate of co-occurring OCD is very, very low. In fact, like almost trivially so. And so I kind of question the degree that it's actually related to OCD. It can look like it because there are these signs and symptoms that seem to resemble OCD, like avoiding things, and avoidance can often take a ritualistic-like appearance to it. And people being, frankly, kind of focused on when they may feel at risk of encountering a sound. And so, many people might interpret that as being like an obsession. And so I think there are ways in which the public may view it this way, or among sufferers. And it's very easy for clinicians to end up thinking that way. But in point of fact, I think that that's an open question to what extent they're related with one another. And maybe to back up a little bit, just to remind everybody, misophonia literally translates to hatred of sounds. The person who coined that term is named Paul Jastroboff. He's an audiologist emeritus now at Emory University. He himself actually has said it's a little bit of a misnomer because people with misophonia are mainly bothered by certain classes of sound, most often respiratory noises like breathing and snoring, or gustatory noises like chewing and swallowing. And so those seem to be where a lot of sounds are, but it's not restricted to that. And in fact, Eric and I developed a checklist of symptoms that are, a list of different sounds that fall into a wide range of categories. So that's a little bit of the diagnostic feature of it. And there's a strong emotional reaction that goes with it, such as anger, disgust, sometimes anxiety, that can emerge in reaction to sounds or in anticipation of sounds, like through visual triggers.
Wonderful. And Dr. Storch, if you don't mind, can you share a little bit about what that symptom checklist looks like? So what are a lot of the main symptoms? Where would we see it? And how would we know, someone we love or care about is suffering with misophonia?
Yeah. Dean's response was terrific as usual. The general kind of concept is again this kind of selective sensitivity to a variety of sounds. It can be general in a sense, or it can also be, and often is, very specific to individuals close to the affected person. So the way that mom says a certain word, dad's chewing, sister's breathing, and so in a way that's, again, sort of similar to different kind of obsessive compulsive symptoms. Some of these can be graded. So for example, my friends are only slightly distressing, strangers even less so, but my siblings are more, my parents are the most. Now, as Dean put, there are a whole bunch of different characteristic triggers that come up. And they often include things like breathing, the way certain words are pronounced, an S sound being stated a certain way, eye blinking, yawning, choking, chewing. A whole host of things kind of within, again, that respiratory piece. Or Dean, I love the word you used. I don't know if I can say it. Was it Gustatory.
Oh, gustatory.
Yeah, I was impressed. I was writing that down for if I ever take the GREs.
Oh, did you go to grad school the year that they also waived the GREs?
No. You can actually Photoshop some of this stuff and then put it in a frame, and just it seems to work. But but within those spaces, what's also sort of interesting is that occasionally movements that don't emit sound can also be triggering. For example, someone crossing their legs, if you will, and like they might move their foot like that, or just kind of twiddling something. But again, very, very distressing. What's sort of interesting to think about when we're coming up with this characterization is that for many folks that we see in clinic, they really have more extreme presentations with distress or impairment. So it begs that question of, are we just missing a significant subgroup of folks who have that sound sensitivity, but that aren't going to come in to see any of us because it hasn't crossed that line? But we're still at the phase where we're trying to accurately develop a consensus diagnosis for what this looks like, and then understand, is this something that's a standalone condition or reflective of multiple types of psychological concerns? So very much in our infancy in the field.
And I've heard of some individuals having this kind of really visceral reaction to people typing on a keyboard. Would that also kind of fall into this? And do you guys see that often? And, I would think in particular with students, right? That's something that like you're around keyboards a lot, usually. And so what would that be like?
Yeah, too much these days. But yeah, absolutely. Things like that can have exactly the same effect. What's, sort of more helpful about certain scenarios like that is that they're a little bit more controllable than some of the involuntary aspects like chewing, breathing, blinking, yawning. And so a lot of times what you'll get are these households that are really shaken up because there's a person that can't tolerate those symptoms. And so the family is forced to contend with what to do, in their presence, and in the emotional reaction that is being pointed out can range from things like disgust and anxiety, but also to irritability and anger, especially in some of our younger ones that may struggle to control their response.
And I wonder, Dean, when you see individuals seeking treatment, I guess one of the things I'm curious about is it always the individuals or is it sometimes the family members? Because what I can hear is like maybe the individual's like, well, if you guys just fix this, I'm fine. Like it's more of you than me. And, but it driving family members really nuts or like having a big difficulty with living in this household with all these rules.
Sure. So I think like any treatment that might be done, there needs to be a good functional assessment of what the relationship is between the symptom and other environmental contingencies. And so, in our lab, we just wrapped up an adult treatment trial and we have a children's treatment trial going currently. And you do see, there are two sides to this. So one, someone may have bona fide misophonia and then family members who might also be frustrated with having to live with this, might do things that are just frankly unhelpful. And it requires a lot of effort to help people do things that would be more productive, just by way of partly helping people understand, here's this symptom, your family member, your child, husband, wife, sibling, they're not here trying to make your life difficult. They're not reacting to you because they have disdain for you and are reacting to your snoring as an excuse for this. Many people will feel that way and feel like it's a personal affront, especially if you think about the typical reaction. So let's say a not uncommon one would be snoring or other kinds of respiratory sounds. And so the family member in question who might be the target of the individual's sound intolerance will feel like, oh, well, this is a personal affront. And then, in fits of anger, we as people generally do things that might be unhelpful. And so someone like that might, we've seen this in our lab. We've seen family members where, we have to help them to not engage in these unhelpful, angry reactions as part of treatment. Now, to be fair, there are some other instances that we've observed in our lab where there have been, on functional evaluation, some real bona fide interpersonal challenges between members of the household that predate the onset of misophonia. And so it can become a little bit difficult to disentangle. And clinicians have to tread carefully, because you really don't want to be in a position of invalidating someone's symptoms, because they probably do genuinely feel distressed by this symptom. And so it ends up being a much more complicated issue. And I don't think we have a good answer to it as yet. The more common scenario, though, is that the misophonia symptom starts and then it takes shape on its own in a lot of ways that become problematic. And then you see it evolve in a household where, people are at odds with one another.
And do we see an age that it typically onsets, or a time frame?
So I don't know that there's any good evidence on this. I mean, most of the people that we've had in our lab, at least, report that it has started in childhood. Some who say that it got worse as they got older, sometimes after some, developmental event like post-puberty. We've had, in the adult trial, we had some women who developed it after pregnancy. But I don't know that I don't want to really hang my hat on any of that per se. I think there are a lot of ways in which it can develop over time. I do want to mention, by the way, I feel like it's important to highlight something before we go too much further with this, is that I think for most people, there's a recognition that there are some sounds that we find bothersome. So it's worth remembering that, like so many things in psychopathology, there is a continuum on this. I like to mention The Onion, I think, captured it well years ago with a headline that said, by report, that snoring may increase risk of having throat slit during night by loved one, because I think that represents very well the idea that under right conditions, all of us will find certain sounds really to be bothersome. And so we really should, kind of keep that in mind, particularly when, trying to address this with clients, that, this is something that could be part of a continuum. And the goal in treatment is really to react in ways that are in line with what most other people would find to be normally unpleasant. That it's not that we're going to, at the end of treatment, say, what's at the end of treatment, you're going to love respiratory noises. Unlikely. And so I think that it's usually helpful to put in a better context for people.
Right. There's a difference in tolerating and loving, right?
Exactly. Right. And I think sometimes it's hard to, keep that in mind, because clients may come in with different expectations.
Yeah, absolutely. So I want to read some of the examples, and maybe Dr. Storch, you could that people are posting, that you could kind of confirm if it sounds like, of course, we can't say whether or not that you have this diagnosis, but if it sounds like it could be. So first, Kelly at 1106 said that when she was a kid, she wasn't able to be in the same room when one of her siblings would brush their teeth. Her mom would chew her gum. She'd have to plug her ears. Now she has trouble sitting next to her husband on the couch without plugging her ears. It's even the motions of eating. Mm-hmm. So sounds like could be symptoms. And then, so we'll get to some of the other questions are about causes and symptoms, causes and treatment, which we're going to get to shortly. Someone said, I've been really bothered ever since I moved to an apartment by the traffic noise. Could this count?
That one sounds a little bit less characteristic of misophonia, and more just that's an objective stressor.
And then lots of people talking about noises like chewing, snoring, TV, radio, rappers, even stomach growling, like someone's, physiological kind of sensations and noises. And I think all of these would certainly potentially fit into the category. So let's shift a little. And Dr. Storch, if you don't mind, let's start with treatment. So what does treatment look like? How is treatment maybe similar to OCD treatment? But just in general, what are some of the steps and how does it unfold?
Sure. So I remember when we first started seeing child cases, which is now about 15 years ago, 13 years ago, somewhere in that ballpark. And our first thought was that this sort of sounds like OCD. It looks different, feels different, but we can conceptualize it behaviorally in that same framework. And so we started, doing exposure therapy, and the first couple of cases did really, really well. And so we published a case report or two, and felt good about ourselves. And then our next couple of cases didn't do as well. And so we accrued some experience, and we learned some things, and we continued to learn a lot, and we need to learn much more. So one of the pieces is that we don't use exposure therapy as a kind of a primary component. So from a cognitive behavioral standpoint, as our prevailing framework, there are a few different elements to it. And we sort of think about it as a treatment box. And some things are going to be more relevant for some individuals and less relevant or helpful for others. And if we just do a one-size-fits-all model, that's not going to be particularly effective. So one of those domains is starting off with just broadly education. About the cycle, about the challenges of kind of giving in and accommodating too much. So very much similar to how we might think of standard kind of exposure and response prevention treatment. Then there are other components that come into play. One of them is a focus on distress tolerance and how we get people who are upset really kind of calming themselves in the face of these triggers that we just can't eliminate because it's part of life, like your spouse is snoring. So that's an element. A second element could include cognitive therapy, where it goes in this notion of how do you kind of put these places in their context, but also how do you externalize them and try to separate yourself from them a little bit more successfully. A third area becomes how do we kind of imaginally reconceptualize what we're hearing. So there's some really exciting research that's emerging that you could have the exact same sound, but if you have a visual component that differs, then you have a very, very different emotional response. So for example, if someone was, chewing and you have a video of that person chewing, as opposed to a video of someone walking through snow, kind of crunching the snow, there's a completely different emotional response to that. And so we're trying to use that to engage kind of imagination to again, break that connection between the visual and the auditory and then the emotional response.
It's really interesting because when you were just talking about distress tolerance, I was thinking like, oh, it is so different than traditional like exposure or ERP therapy for OCD.
Yeah, so that was the piece I was going to go into, because for some exposure can be helpful, but for others, the response is like, absolutely not, this is awful. And in fact, I just get really, really upset. And so I think you have to personalize the intervention approach with the components that are going to be most relevant for that person. And so that's one place where it really does differ quite a bit from treating folks with OCD. Where we're pretty confident in this general approach, and we'll personalize it, of course. But here, for some, the exposure piece is just too in their face and too distressing. That said, we really want to, and Dean said this well, we really want to make sure that we're not letting misophonia gain ground into the person's life and keep families from eating together or people from doing certain things. And so that's a really central focus of a lot of the work.
And so I guess one of the questions I would have as a clinician, and I bet a lot of our viewers have as individuals who may be living with this illness, is how does one determine which treatment's going to be right for them? I think when we are advocating and doing kind of some advocacy work for OCD, we'll always say, find an ERP specialist, and make sure someone's doing ERP, that's critical. That's the component. How do you know which approach to kind of take and which one might be better? Dean, do you want to tackle that?
Yeah, sure. Well, I guess as a first question is there someone that you are able to get treatment with that's familiar with misophonia? That's the most frequent question that I've heard. When we've had people enroll in our trials, usually at the end of treatment, for the most part, we've been happily seeing people improve, but they're not necessarily done with treatment. And then we're trying to track down someone that is at least familiar with the concept, which is, just a rare thing. And then once you find someone, you hope that they have a sophisticated understanding of CBT. So like what Eric described, I think is a great illustration of how CBT is supposed to be ideally conducted. There are certain principles that we know are true. And for the individual who's suffering with misophonia, they may have a sense of whether or not they're too sensitive to sounds, or their emotional reaction is so strong that to do exposure in the way that we understand it, it just may be too daunting to consider. And there's another side to this, though. One of the challenges that is worth considering. And so what we've done in our work is we've generally emphasized exposure, but there's like a really important caveat to that, because I think the prevailing notion in some of the different forums that people with misophonia may go to, they've heard repeatedly that exposure is harmful. And I would concur that if done improperly, it is harmful. The flip side of it, though, is that, what brings people to treatment often is that they're inadvertently getting exposed to stuff all the time. And the world is an uncontrollable place filled with things that are constantly upsetting. And so the role in treatment, and a good CBT clinician should be able to do this, is really to carefully think about what are the steps in a hierarchy that will permit someone to be able to engage in exposure, and perhaps even as a bridge in treatment, go ahead and engage in avoidance briefly between sessions as you're gaining mastery, because you're constantly getting exposed to things. So let's say if it is snoring, right? So snoring is a not uncommon one for people who come to treatment. Or other gustatory noises. And so maybe they need to be selective about when they are with family members as they begin to approach some of these things. And that could be done through some exposure practice, but it also requires some cooperation and understanding on the part of the family. And so, in complementary fashion to what Eric was saying, like, education includes highlighting for the family that part of this is going to involve this kind of gradual procedure. There may be days where the person doesn't feel as well and they can't necessarily engage in the way that they did the day before. So don't see that necessarily as a setback. It's just part of the natural process of treatment. And the other thing is, I guess, for providers, thinking about a hierarchy of sound is not something we naturally do. I've consistently noticed that, it really requires a different way of viewing things, but it's kind of surprising because we really should. Any hierarchy that's developed for exposure is based on stimuli. And so why not sound? We usually think of stimuli as visual things or things that you would encounter live as a physical object. But this is, just another kind of sensory experience. And so we have to think about, let's say with chewing noises, there's a difference, and some people with misophonia struggle with squishy chewing noises. And so the hierarchy might go higher to squishy noises. There are other people where it's the exact opposite, where like Jell-O noises are fine, but Doritos are a problem. And so then it goes to crunchy noises. And we have to really think in these dimensions and have flexibility in how we view it for clinicians. So anyway, so I'm sorry, I know I went a little bit off. I strayed a little bit from the question.
No, it's great. But I still want to go back to that first question that you raised, that people ask you, that I know our viewers would want to know also, which is, so how do they find a therapist who, it's not the same as, like, for OCD, we'll say, go to IOCDF search bar and then, figure out if they've had ERP background and training. Like, what should they be asking? What should they be looking for?
Well, I imagine most people that practice exposure therapy are probably going to be a reasonable first start, because they would be able to think about hierarchies, and they also routinely do things like stress management. So if you went to an anxiety disorder specialist, someone who regularly practices CBT, that would probably be someone who would have enough of an understanding that they could apply evidence-based approaches to misophonia. Now, if somebody is open to it, let's say they say to the sufferer, hey, I'm not really familiar with misophonia per se, and then the sufferer describes to them what it entails, there probably would be an opportunity to bridge that gap a little bit if it's someone who, in fact, is familiar with evidence-based approaches to treatment. So that's probably going to be your nearest thing. There's not right now a network of misophonia experts. And so other than, let's say, Eric and I, or some other people that are recognized for treating misophonia, the other source that that they might consider going to would be audiologists or ENT specialists.
Yeah. And so really, it sounds like from a therapist perspective, really look for a CBT provider and then kind of understand if they have some background in treating misophonia and or kind of some exposure and hierarchy-based work.
Exactly.
So a couple questions that have come in. So some people have talked about how what you mentioned earlier, actually, Eric, where some family members or individuals can be much more triggering than others. So this kind of like the noise is there and it's bothersome, but it's really bothersome if it's a certain individual. And then somebody also talked about how, these noises can be so bothersome to them of someone chewing, but other individuals don't even really hear it. Like it feels so strong and so loud to them, but like someone else isn't even noticing it, which I think is interesting.
Yeah, it sure is. It sure is. And the one point that addresses this and follows from Dean's comments is that the challenging part is we're really in our infancy in the field. So that's kind of the challenging piece. A positive is that there's a foundation called the Ream Foundation that has made a sizable investment in really pushing forward the field but in a way that frankly wouldn't have taken place without their support. And what's kind of cool about it is that they've made investments in multiple different areas to try to push the field over, including intervention and assessment and understanding the pathophysiology of it. So we'll get there. It's just not all there yet. I think that kind of I guess specificity of the trigger can be really, really difficult for everyone involved. And I think as for parents and for loved ones, you're sort of stuck with this question of how do you effectively respond? What do you do in that case? And I think like OCD, the initial loving response is often, I'm going to give in. I'm going to not make this person upset. But also like OCD in most cases, that's a response that then kind of, it digs the hole a little bit deeper and deeper and becomes one of those areas that we want to try to target, with help.
Yeah. And I think in particular, one of the other things I was just thinking about is with COVID, I wonder if we're seeing an increase in the distress because right? Like I can just imagine if certain family members and certain behaviors they engage in are the most triggering, but we're trapped in a house with them, right? And we're not able to kind of, maybe before we would just go to the library or we would go, somehow get away, but we can't. Are you seeing any correlation there or any increase in, people seeking treatment during this time?
Absolutely. I mean, it's a fantastic point. We've had several people who have described exactly that they're working from home and, their family members also working from home and they're there all the time with them and it's driving them nuts or a kiddo, because we have a study looking at kind of capturing the symptoms in kids and understanding it hopefully a bit better, but where the kids are saying exactly that. I couldn't go to school and have my break. And so that has been a particularly difficult kind of piece of the whole puzzle of COVID. And I think the stressors on top of it do exacerbate the overall problem. So sort of a perfect storm.
Yeah, I would echo that. I mean, this is, the nature of COVID-19 in terms of its impact on mental health generally. I mean, we know that it is, a multi-systemic kind of impact. And so if you are struggling with stress management in general, then this is going to be a tough time. And if you have misophonia, like I said at the beginning, what drives a lot of people to treatment is that they're inadvertently getting exposed to sounds all the time and it's uncontrollable. And then here you are at home and, a lot of people will come in and report it's a particular family member that is the problematic source of sounds. And so now it is way out of control. There is no escape from it. You get very little relief. And it comes across as hostility for some family members. They're like, oh, you really don't want to be around us. And, a lot of times the person suffering from misophonia, they're not intending to offend. They just find that the sounds are too painful to tolerate. And so the whole thing just really leads to these they're very difficult spirals.
And somebody else left a comment saying that sometimes clinicians who treat selective mutism are also familiar with this and maybe a good place to start. And so that would be an interesting place to think about. So as we think about treatment, and we've talked a little bit about just kind of some of the steps and what to look for, I'm curious of how family members can best support, because that's a question we really get a lot of in the OCD community and in the community here at the foundation is how do family members is it similar to OCD where we either end up enabling and, potentially giving in, or how do we still live our life? Like, what's the balance? Any tips you have, whether you're working with a child or an adult who lives with family members? Dr. Storch.
Sure. I think one tip is, with everything is have empathy, have grace, be thoughtful and kind of listen. Within that, I think there are several important things. One is that point I made earlier about not giving ground to the misophonia, similar to OCD. So what that could look like is not letting family members who have these symptoms, not having them eat separately or do everything separately, but still maintain family cohesion or relationship cohesion, and try to limit any sort of unhelpful accommodations. Now, sometimes accommodations can be helpful, and if we think about this along the lines of trichotillomania, where someone that may have a bald patch may wear a hairpiece, and that helps them feel better or contend with being out in public or how they feel about themselves. And so it may be that certain kind of sound suppressing machines may be helpful for some people. But we want to try to engender flexibility in any sort of kind of coping tool, like anything else. We don't just want to rely on that one thing, because that certainly won't work very well. I think another area can be teaching people, how to calm themselves, how to contend with difficult affect, which could come in a variety of different areas or ways, like relaxing oneself, through progressive muscle relaxation or deep breathing, or kind of stepping out of situations in one's mind to kind of regroup and then re-engage. But these are some I think really straightforward ways that the family members can help the loved one who's struggling.
Wonderful. Yeah, I think that's really helpful for us to just always think about. And, I think for family members, sometimes I can imagine this could be really frustrating if you're feeling like you're triggering your child, but at the same time, you're just trying to live your life. And so trying to find that balance could be tough. So Dr. McKay and Dr. Storch, as we really start to kind of think about wrapping up, would love to get some final thoughts from both of you. Takeaways. So really, what are the biggest takeaways when you think about misophonia and how we treat it? What do people need to keep in mind? How do they start, imagining how to get appropriate treatment, because what should it look like? So how many sessions before they start to realize it's working or start to see some relief? OCD, we know typically 12 to 16, is it different? What should they expect?
So, I usually tell most clients the following, and I think it's helpful for people to set their expectations properly. And that is that it's easier to do better than to feel better. And so what I'm referring to is that, in the early parts of treatment, some of the things that may be improving are going to be observable to family members, but may not be felt by the person who's suffering from the condition. So, a misophonia sufferer is no different in this regard. Well, you start out with treatment, there's a lot of pretty clear behavioral approaches to treatment, and probably become evident to family members and friends if they're engaging in treatment and they're able to successfully navigate some of the demands of treatment. I would say in 7 or 8 sessions, there should be some observable signs that things are improving. And then probably, not unlike with OCD, if we're, going to keep that analogous to what we're considering here, probably around 16 or 20 sessions, people should be feeling better in addition to doing better. But I always really emphasize that, because people can be frustrated that they're in 5, 6, 7 sessions working hard and they don't feel better, and they report that they don't feel better, that can really be problematic.
And Dr. Storch, if you want to just give some takeaways of so main things, I know you talked earlier about distress tolerance. We talked about, sometimes incorporating exposure therapy, but main components of treatment and takeaways. And then another question that was submitted is, please advise evidence-based therapists how to provide treatment for conditions such as misophonia for children when there's not an evidence base such as a randomized control trial. Is that true that we don't have any randomized control trials to date?
So there will be one coming out very shortly. And there's a group in Amsterdam that has really been at the forefront of this work, and they use a cognitive behavioral approach that's sort of similar to what we talked about, but with some differences. Like, one is that they have large groups involved, whereas a lot of our work tends not to be group based. But it still doesn't address, what do we do with kids, or the fact that there are different components to treatment, and some of those are given primacy in different areas. So I think stepping back for a second, Dean's response was terrific as always. I guess one kind of parting thought is when the International OCD Foundation was started some years ago. It was really started because there was a kind of a gap in the field. There wasn't much out there. There wasn't much guidance. And what we've seen, with huge thanks to the foundation and huge thanks to Dr. McIngvale for her work, is that we're here where we are now, which is dramatically different than actually when I started, about 20 years ago. I mean, it's night and day different. And so there's going to be a bit of a process of getting the misophonia field to where we are today. The good news is that we aren't starting from scratch. So we have this kind of cadre of brilliant therapists and docs out there who are doing great work and are well equipped to use these kind of evidence-based principles in application here. We're aware of it. We have forums such as this one talking about it. So we're much ahead, and we have a foundation really supporting that research as well in a particularly robust manner. So I think it's going to accelerate the pathway forward. So that's where I'm thinking. I think, identifying therapists who really think in this cognitive behavioral framework, but are, flexible and able to adapt to the needs is really kind of that best way to go. And a lot of the tools that we're using to address the symptoms are cross-cutting. So we may use components of this with anxiety, or OCD, and of course with misophonia. So I think a lot of hope.
Any self-help books or resources that exist, or treatment manuals at all?
Not yet. Okay.
Yeah. So again, I think the point of this and what Dr. Storch was just talking about is that the point of us talking about these things, that we see how many people are wanting advice, wanting feedback, wanting to kind of understand how to get appropriate treatment, right? This is what pushes things to move in the field, right? This is what allows us to continue to recognize gaps that exist so that things can happen. And I think that, one of the big takeaways is that we're not at point zero, right? It sounds like there is treatment. There's treatment that works, and it sounds like we can help move people forward, but there's a lot of work to still be done. So Dean, I know earlier you spoke a little bit about how actually we don't see a big correlation between OCD and misophonia, but one of the questions was, are you seeing it commonly comorbid with any other disorders? So ODD, externalizing disorders, ADHD, or phobias?
So the most frequently occurring additional diagnosis, or just diagnosis, that we've seen in the adults have been mood and other anxiety disorders, like generalized anxiety disorders. In the kids sample, kind of similarly, mostly it's been anxiety and mood problems, which, is on reflection, and maybe with hindsight, it's easy to make this prediction post hoc. But alluding to what I mentioned before, the individual is suffering with a condition that in their daily lives is completely out of control. And so that fosters a sense of helplessness that can drive bad mood. If you think about any occasion that you might be incapable of managing an aversive experience, that usually leads to some depressed affect. And so it's unsurprising. And then generalized anxiety kind of goes with that because of that high overlap between GAD and other mood disorders. So that's what we see the most frequently. Like I said, my lab, we're working on writing it up. We got sidelined because in our lab, we have a lot of COVID-19 related research going on that obviously is a little bit more time demanding. But OCD was the 4th ranked condition in the list of diagnoses for the adult sample, and 4th, like a distant 4th. So out of 42 participants, there were 3 people that had co-occurring OCD, and none of those individuals had it where the misophonia was functionally related to the OCD. So in other words, it like stood aside separately. So even in those individuals, I would not say that it was related to OCD. It just happened to co-occur. Like in medical science, it would be kind of like you have high blood pressure and you broke your leg. The broken leg has nothing to do with high blood pressure. So in this regard, it's sort of analogous to that if you want to think about it for how to understand the way they were basically not related to each other.
Sure. And I think one of the points you bring up that I, think is important for our viewers to recognize as well is that when we're talking about the common comorbid conditions being mood disorders and anxiety disorders, we know the evidence-based treatment for those is CBT, right? And so again, that kind of reiterates that notion of like start with a CBT therapist. So somebody who's really qualified and understands CBT, because we wouldn't want, right, you to get treatment for one disorder and not the others if they also may be, a current diagnosis that you're dealing with.
Since we're mentioning diagnoses, I'll just add one other little note, because I've seen in different forums, people talk about misophonia, and a lot of clinicians, I think justifiably have some viewpoints on this if they've seen some individuals with misophonia. I think under controlled lab work, there is also not much of an association with prior trauma. I mention this because that comes up a lot where people anecdotally report it, and it's a big draw in many therapeutic communities, but that too is not something that we've really seen a lot. It seems to really, when present in the way that we're talking about it, it's a bona fide standalone problem, and it may foster mood and anxiety problems.
Wonderful. Very helpful. Any final thoughts from either of you, Dr. Storch or Dr. McKay, just to kind of end with as we give viewers some hope? And thank you so much for opening their eyes to the diagnostic criteria, and then of course talking about what help would look like and how they can start that journey.
No, just thank you for hosting this and all that you do to kind of bring attention to important problems like this and within the OCD camp. I think that hope piece is such a critical one, that I saw a couple of comments where people were able to identify therapists and, that were able to help them, even though perhaps they were OCD therapists. And so those clinicians that really understand those cognitive behavioral principles can often be very, very helpful.
Definitely.
I'll also echo that. Thank you very much for hosting this. And, I hope that this will increase awareness of the problem and maybe help promote greater applications of evidence-based approaches to treatment. And I know there was someone commenting, I had mentioned before, I posted this elsewhere on Facebook, and I've been getting like some tags showing up while we've been talking. I've been trying to pay attention a little bit, some questions coming into me personally. So the idea of evidence-based in this regard, maybe even if we take a step back from that even, CBT practitioners are principle-based. So we know principles of behavior that are being applied. And so it's true, misophonia does not have a robust evidence base, although that's changing. But that doesn't mean we can't do anything. So if sufferers come to someone who is a well-trained CBT practitioner, then hopefully that practitioner will, as a scientist practitioner, help contribute to the evidence base. So I hope that clinicians who are viewing this will feel empowered to maybe gather some data and contribute to the field on this in a meaningful way, because really, just because Eric and I have talked about exposure and stress management and other CBT approaches doesn't mean that that's the last word on it, like hardly. There are so many other ways in which we can reasonably think about this that should be investigated using principle-based approaches to treatment.
Absolutely. And one of the final questions to ask that somebody asked was just kind of what treatment is most effective for mood and anxiety. And so I want to kind of push CBT interventions as really being kind of what we would recommend as the gold standard for CBT, anxiety, and OCD. Of course, for OCD, we'd recommend specific ERP, but this has been so helpful. We're so grateful for the opportunity to shine a light on something that isn't talked about a lot. And again, for us to continue to recognize that there's so much work to do in the mental health field in general. And so we're all doing our part to chip away. Thank you all for listening. Thank you for inspiring so many. And as always, help and hope are always available. Thank you all.
Hey man, this was fun.
I will catch you later, my friend.
Yeah, catch you later. Take care.